Thanks, Craig and Chuck. No, it's not a typo up there. This is 2019, which many of you are wondering, why are we talking about topics from 2018? Isn't that really old news? And this is why. And many of you who take our expert space learning program will understand this. It turns out if you teach a learner just once, they only really remember about a quarter of what you say. And the speakers up here should keep that in mind. If you teach them something a second time, that doubles their retention of what they've learned. Probably more importantly, if you ask them to problem solve with that information, that almost triples what they've learned. So let's do a little space learning and, most importantly, talk about a few patients. Let's talk about a day in the operating room. Your first case is an ileostomy closure in a teenager who had this done for complicated inflammatory bowel disease. As you're finishing the case, which took a little more intraperitoneal dissection than you were hoping, the intern you've done the case with is called down to the emergency department to do a trauma, and horror of horror, you have to write the postoperative orders. Show of hands, you guys know I'm not a big fan of technology, so we're not going to use the ARS system. Show of hands, who would order for maintenance fluids D5, half normal, saline with 20 of KCl per liter? Like I would. Unfortunately, I and you would be wrong. Turns out that the use of hypotonic fluids, such as half normal saline, really contributes to iatrogenic hyponatremia in these patients. It's probably more appropriate to use an isotonic fluid, such as normal saline and maybe even lactated ringers, that isn't associated with a hypo or hypernatremia and decreases the risk of having seizures from those electrolyte abnormalities. That was our number 4 TEC topic from 2018. All right, next patient. Between cases, in that 3 or 4 minute turnover time that you have, you're asked to go downstairs to the emergency department and see a patient, this time a 9-year-old with right lower quadrant pain lasting 18 hours, focused right lower quadrant tenderness, a mild leukocytosis, an ultrasound that shows an enlarged appendix, but no fecalith and no free fluid. The parents have been Googling and are interested in this concept of non-operative management of appendicitis. Again, show of hands, how many people in the room would offer non-operative management for simple, complicated appendicitis? All right, don't shoot the messenger. Turns out that at the initial therapy, non-operative management of appendicitis is pretty damn good. 97% effective. If you measure the outcomes, they're pretty much equivalent to appendectomy, except that patients who have non-operative management have fewer disability days and are back at school quicker. The real proof is in the pudding is long-term, but even after a year, 80% of those children have avoided an appendectomy with a 14% recurrence rate. I'll leave it up to you whether those numbers are sufficient or not to offer non-operative management of appendicitis for your patients. All right, back up in the operating room, anesthesia's got the patient ready. You're presented with a toddler who presents with a large left abdominal mass that's palpable. The fellow tells you these are the studies and throws them up quickly on the computer. You can see the mass there. What is this likely to be? Wilms tumor, and the CT scan shows that there's a lung met. Again, show of hands, stage 4 metastatic Wilms tumor. How many people would do a biopsy and a Brove? Turns out that the presence of metastatic disease, lung mets particularly, should not preclude the resection of the primary tumor for Wilms tumor. Wilms tumor COG protocol violations were our number 2 top educational content for last year. What else do you need to do in addition to the nephrectomy? Somebody say it loudly. Lymph nodes, exactly right. If you do not sample, thank you. If you do not sample, you've been trained well. If you don't sample lymph nodes, they're kind of presumed to be positive, and that upstages the patient. That's a real problem. So again, you can still resect the primary even if you have metastatic disease, and don't forget your lymph nodes. That was TEC topic number 2. All right, let's go back. Your patient who you did the lap appy on, the parents agreed with you that laparoscopic appendectomy was the right thing to do. Now 12 hours later is ready to go home from the short stay unit. The intern is down, putting in a dislodged G tube. in the emergency department, and the nurse calls and wants to know, what are you going to write for pain medicine for this patient to go home? How many people, show of hands, would send a lap appy home with a narcotic prescription? I'm so proud of you. Those of you know that opioid-related deaths have quadrupled. Emergency department inpatient hospitalizations for overdose in children now has doubled. Most of the source of these opioids come from appropriately or legally written prescriptions from healthcare providers. A significant number of adolescents who are prescribed opiates will misuse and then subsequently abuse those opiates. And a pretty high number of them are still on opiates 30 or 60 days after their procedure. The suggestions are, don't prescribe opiates unless you know your patients need them. And for the vast majority of our procedures, they probably don't need a narcotic prescription. If you're going to do a prescription, do a smaller quantity to limit the amount of pills that are out there in the community. All right? And then finally, you really need to encourage good practices for disposal of those opiates after the patient is done with them. For those of you who are interested, these were our top, and our David Letterman fans, these were our top 10 top educational content topics for 2018. All of these have questions and expert. All of these have learning objectives in the NAT. If you're interested or don't know why these are up here, that probably means you don't know why they're up here. So go to those resources and learn about it.